Well, thank you very much to the planning committee for the invitation to be here. So on behalf of my authors, I'm happy to talk about our results from this study. No relevant disclosures. So as retinal surgeons, we know, in terms of clinical relevance, we know macular hole surgery with gas tamponade, vitrectomy and gas tamponade is gold standard treatment for macular holes. We know the only modifiable factor we can control after surgery, the variable we can control, is face-down positioning. We know patients do not like doing face-down positioning, and we know there's potential risk of serious complications, including a patient of mine who had a pulmonary embolism during recovery. At the same time, we know two things about clinical practice. Surgeons like recommending face-down positioning because intuitively we think it helps. And secondly, we don't know how much face-down positioning we should recommend. So we see a lot of variation across the world from 2 days up to 14 days. Given the uncertainty, my colleagues and I decided to look at this research question, where we looked at patients undergoing vitrectomy surgery for idiopathic macular holes. The intervention group underwent face-down positioning. The control group underwent no face-down positioning. We looked at 7 patient-important outcomes at around 6 months, and we only looked at RCTs. So in terms of methods, we searched multiple databases in duplicate. We looked at, for RCTs, looking at face-down against non-face-down. We looked at 7 clinically important outcomes that were based on clinical expertise opinion on what those should be. We carried out random effects modeling, looked at subgroup analysis, and certainty of evidence. Our subgroup were pre-specified before the study, and we had a hypothesis on the direction of effect. We looked at 3 clinically relevant subgroups: small holes versus large holes. Does face-down positioning help? Type of gas used, and duration of positioning, less than or equal to 3 days or more than 3 days of face-down. As clinicians and surgeons, it's important when you look at meta-analysis to look for certainty as well, and this cartoon from the BMJ nicely illustrates the importance of that. A meta-analysis will give you a point estimate confidence intervals, but are you confident that those findings in fact tell you the truth? We looked at the GRADE approach and Eisman to look at the certainty of evidence for a meta-analysis. So in terms of results, when we carried out the search, we identified 8 unique RCTs. And if you look at macular hole closure rates, you see the pooled estimate, the diamond at the bottom, it crosses the vertical line, which is a line of no effect. We're looking at risk ratios here, telling us that face-down positioning versus no face-down positioning did not have any impact in terms of hole closure rates. If we look at the 95% confidence intervals, they go from 0.99 to 1.12. So next thing we did was think about what is clinically important outcome here, a minimally important difference that we would want in terms of improvement after face-down positioning. The authors decided 10% difference would be clinically important. Because the confidence intervals are larger than 10%, we have imprecision in our confidence intervals in a measure of effect. That is one of the reasons our certainty of evidence was lowered in this case. What about visual acuity? Here we see the pooled estimate lies slightly to the left of line of no effect, demonstrating that vision is better if we do face-down positioning. Let's look at the 95% confidence intervals. They go from 0.12 to 0.01. This is logMAR visual acuity, so 0.1 is equal to 1 line of vision, Snellen vision. And again, our MID, as we defined in the paper, was 1 line of vision or 0.1 logMAR. Once again, our confidence intervals are wider than our minimally important difference, so the effect may be important or may not be important, and that lowers the confidence of certainty. What about macular hole size? We looked at the subgroup analysis, small macular holes less than 400 microns versus greater than 400 microns. You see the point estimate for both of them crosses line of no difference. We see the last line that they're looking for tests of subgroup differences is not significant, telling us that there was no significant difference in terms of macular hole closure rate for small or large hole in terms of face-down positioning versus no positioning. We did subgroup analysis looking at visual acuity outcomes. Remember, there was a signal for better vision. We again divided in a subgroup in small versus large macular holes. It appears that the benefit of visual acuity was coming from patients with large macular holes doing face-down positioning. But we need to look at the subgroups individually. The PASU paper contributed majority of patients to one of the subgroups. It only included large macular holes, so it did not contribute any patients to the small macular hole subgroup. And when you have that you basically lose the effects of randomization. So the validity of this subgroup is relatively, or certainty of evidence is relatively low for the subgroup analysis. If we looked at the impact of positioning, less than or equal to 3 days versus more than 3 days, once again, both pooled estimates touch or cross line of no difference. If we looked at type of gas, no difference in terms of face-down versus no face-down positioning for each of the pooled estimates, except air, which had very small number of patients. If we looked at ocular adverse events, no difference between face-down versus no face-down positioning. A number of other patient-reported outcomes, we simply could not even carry out a meta-analysis because the data did not exist. So a large area of evidence gap exists in this area in terms of looking at quality of life and patient-reported outcomes after macular hole surgery. So what are the conclusions we can make? Well, this was the most up-to-date, unbiased estimate of the treatment effect of face-down positioning versus no face-down positioning on clinically important outcomes after macular hole surgery. The evidence suggests that face-down positioning may result in little to no difference in macular hole closure rate. Face-down positioning may result in a slight benefit in terms of visual acuity. Our subgroup analysis, low certainty again, suggests that face-down positioning does not increase hole closure rate for a subgroup analysis done at 400 micron cutoff. Our low certainty of evidence in a lot of these outcomes certainly points to need for further evidence generation, whether that's a large definitive RCT or further IPT level meta-analysis. So what do we do with this information in clinical practice? I think when we look at evidence-based medicine, we need to look at both the combination of clinical expertise, best research evidence, and certainly patient values and preferences, and these should be an important part of the consent process when we talk about positioning to our patients. I'd like to thank all my co-authors, and thank you for your attention.
Thank you very much for your excellent presentation. I think before we go to Professor Nori, is there any question from the audience?
I have a question on the posture. And my question refers more to the retinal detachments. We all have these very important data that the retinal detachment, macular off retinal detachments have to be operated promptly. But are there any data that show that the preoperative posture plays a role in the visual prognosis? Because I can say from my experience also, I operate on bolus retinal detachments. I put them on the next day, I operate them, and I see that the retina is almost attached. Sometimes I think I'm operating on the wrong eye. So are there any data that show that the anatomical changes that take place in these 24 hours of posture until we operate give us some advantages on the visual prognosis? Thank you. Or does it make any sense to include them in clinical trials?
To be honest, I don't know if a preoperative posturing was taken into consideration for the study, for your study, for the retinal detachment, the study you presented.
For the post-op.
The preoperative posture.
No, we didn't record that. It's not in the database.
Okay. It doesn't make any sense to include them. It doesn't make any change in the visual acuity because the retina is almost attached. So it could save some time.
Because I think if we position the patient, maybe the macula is going to reattach before the surgery. Makes sense.
Hi, short question. You didn't mention the surgical approach, and in the last few years, the surgical approach is changing, comparing on the ILM aggressive. You are less aggressive on the ILM. So I think this is a bias that you should consider because change also the postoperative attitude to the patients?
Great. And so the heterogeneity in terms of analysis was moderate for a lot of this, and for that very reason, I think there was a lot of clinical heterogeneity in terms of how the procedure was done. Although I think there was only one RCT that did not peel ILM in terms of just ILM peeling specifically. But I think David's going to be talking about the role of ILM peel, size of ILM peel for macular hole surgery. But certainly that heterogeneity exists in macular hole surgery and any analysis we can carry out.
Thank you. Professor Nori, your opinion about the methodology of this study?
Just to say that was magnificent to see such a beautifully presented and rigorous systematic review and meta-analysis. It's so important. I've got some slides. I didn't bring them along, but I'd urge all of you to understand meta-analysis, systematic review and meta-analysis, and when you're designing your own studies, really engage with, view your study as being a piece of evidence that is going to update that systematic review and meta-analysis, rather than seeing your study as being something in splendid isolation that's going to fix all of the problems. You know, understand the history of the trials, which you'll get a very good view through spending sufficient time understanding the systematic review and the meta-analysis. Understand the stories of those trials, understand why they did what they did, and not what you might think would be the easier thing to do, because usually there's reasons for it. And also I was impressed by the caution with which you expressed your conclusions. The vast majority of systematic reviews and meta-analysis, when done rigorously, sadly report that the quality, the certainty of the evidence, to use the terminology, is low, and you know that there are too many meta-analyses that overstate the certainty of the findings, and that is a disservice to science, not a service. So that was a very good thing, and you know, if you can point out where the research gaps are and what new trials need to be done, that would be very important. And the other thing that I thought was really, really pleasing to see was that on every single graph there was a risk of bias assessment, where you were trying to, however imperfectly, assess how many really good trials were in there, how many not so good trials, and how many, frankly, awful trials were in there, because sadly we do have awful trials. And that, to actually integrate that into the interpretation of the evidence is critically important. I mean, crudely, you'll tend to find, you know, if you get a spectacular treatment effect in a randomized trial, be suspicious. You know, you tend not to get spectacularly big treatment effects in randomized trials. And if you do find yourself looking at one, I think it's prudent to imagine that there might be more under the bonnet in terms of how that study's actually been done. But yeah, fantastic effort.
One important question. One more question, please. One of the important factors that seems to have been omitted, and I wonder if in your analysis you did take this into consideration, non-posturing studies, did any of them specifically state whether they told patients not to lie flat on their back?
Yes, so all of them had specifically told patients no, not to lie on their back. In terms of, we actually did a subgroup analysis I didn't present around the no face down, what they actually told patients. Some told patients to sit up, some told patients to avoid lying on their back. So those instructions were different, but all of them told patients to avoid lying on their back.
Because intuitively, there's no reason to say face down. You said at the start, you made that statement that intuitively, we feel that face down is better, but there's no physics explanation for that, obviously. It's just exclusion of fluid over the macular hole. So sitting up or face down is identical.
Sorry, because we are running out of time. Maybe a very quick question from our president.
It's interesting that the face-down positioning, particularly in the bigger holes, approached significance. The diamond only just crossed the line. But what you did show was that your vision was better. And my question here, because if you're looking at the difference between 96% and 88%, that's I believe that's quite a crude and insensitive statistical test. But by being able to bring in the parametric measure, and I'm going to be shot down here, I feel, of acuity, which is a huge range, that you may actually have a better, and we're trying to improve people's vision, you may actually have shown what we're trying to do. You close a few more holes, you can't show that that's statistically significant, but actually we've shown that the acuity is better, and acuity would be the more sensitive measure. Now, please, just shoot me down, but I've never quite understood why there's this paradox between acuity gain and anatomical success, which has come out in several studies.
Okay, we will discuss later on. I'm going to introduce the last speaker of this session, David Steele, and he's going